Good evening, people. Welcome to Thursday's edition of Community Health Screen UK. In our surgery this evening, I've got a lady called Dr. Zehra Yilmaz, who's been joining me now from London. Hello, Dr. Yilmaz. How are you?
I'm well, thank you. How are you doing?
I'm okay, not too bad. Right. Well, thank you for coming on the show, Zehra. It's really nice to have you here.
Thank you for the invite.
You're very welcome. Right, you're my seventh contestant on the show, so it'd be good to sort of talk about what you do and what you're about. So before I start asking the questions, Dr. Yilmaz, if you can start by explaining a little bit about yourself and your background.
Sure. Well, I have a biochemistry and physiology kind of background. My interest in neurology kind of started during my undergraduate days, and I had the ability, the kind offer from Professor Jumger to do my final year project with him at Imperial, where we worked on neurosciences in cancer, so neurosignaling in cancer, and prostate cancer and breast cancer.
That's quite interesting.
Yeah, my kind of interest kind of increased over the time. After my master's, I went on to do a PhD in the field of oral medicine. So my PhD kind of concentrated on underlying neurological processes in burning mouth syndrome and trigeminal nerve injuries. So this kind of involved translational research where I assessed patients, assessed their pain thresholds, so their thresholds to cold and heat and cold pain and heat pain, using quantitative sensory testing. And I then obtained biopsy samples from these patients so that I could then look at the pain receptor expression within the biopsy samples. So,
what sort of modules did you use? What sort of modules did you use? Like pain scale modules or one-to-one with the patient?
One-to-one with the patient.
One-to-one with the patient. Okay.
Yes.
Whilst they were enduring the pain, or whilst they were explaining the pain?
Whilst they're explaining the pain. So the immunohistochemistry kind of showed increased TRPV1 receptor expression and various other pain receptors, and also nerve growth factors and things like that. So going on from that, I also looked at saliva samples from patients and assessed the actual functionality of pain receptors in these patients. In the saliva. So going on from my PhD, I actually worked for Professor Tara Renton at King's College London. So I worked in the Dental Institute there in the oral surgery department, and I carried on basically with my research on burning mouth syndrome and trigeminal nerve injuries, but I also expanded it onto kind of the psychometric effects of pain and also the quality of life. So I used questionnaires basically to assess the patients and their quality of life and seeing how they have anxiety or depression as well. Kind of most of this was with online questionnaires and also on clinic as well. So I helped with assessing the patients on clinics there with Prof. Renton and the team. Going on from there, I actually then translated this work into Parkinson's disease.
Oh, wow. That's interesting.
So I carried on with designing similar kind of questionnaires, but for people with Parkinson's. So I worked for a year at Cardiff University. And now I'll come back to UCL in London. So I've been working at the Royal Free Hospital for the past year. And it's also been linked with Queen Mary, University of London. So I kind of share my time between the Royal Free and the site at Queen's Square.
You're a busy doctor then, quite busy writing up reports and doing research.
Yes, well, since March, it's actually been...
I think we've all been there, haven't we, tolerating that as well, which is a different pain in itself, isn't it?
Exactly.
Right, okay, well, that's interesting, Dr. Yilmaz, thank you for that. We'll go on to our first question, which is quite interesting. What is pain and how do we deal with it? We can define pain.
Well, pain is actually a sensation that, we all experience at some point, one point or another. It's actually defined by the International Association for the Study of Pain as an unpleasant and sensory emotional experience that's associated with actual or potential tissue damage, or described in terms of such damage. So it's actually indicating that damage has actually been done to our tissue. So it's actually very useful to have pain. It allows us to know that there's something wrong in our body, something wrong that's happened. We can rate it as well on a scale of 0 to 10. So basically 0 is no pain and 10 is like the worst pain imaginable.
Yeah.
However, because pain is very subjective, it's that one person may think that a certain stimulus is not painful.
That's
Whereas
right.
another
Yeah.
person may think it's extremely painful. So it's a very subjective kind of feeling as well.
That's right. Yeah. Do you reckon men would have different pain tolerance to females? Do you think?
Possibly.
Possibly.
Possibly,
Okay.
yeah.
Okay.
Yeah, some men
Yeah.
may try to act a bit more tough and
Yeah.
try to
Yeah.
get a bit more pain than women, possibly. We do
Yeah.
actually see more women.
Okay. Is that because they're admitting, they're coming forward with it and saying, you know?
It could be possibly because the women tend to come forward more to the doctor when they have pain. While the men may try to just carry on with life as it is.
Soldier on, as it were.
Yeah, exactly.
Yeah. Okay. What sort of pain? I mean, is it a different pain for? I know you said you did some sort of like oral sort of like pain at the clinic and stuff. Tooth pain, because that's something a lot of people say, God, I've got this really, really bad tooth pain and it's killing me. I mean, obviously, tooth pain is probably one of the worst to ever endure, other than childbirth. What would you say?
Pain, well, yes, pain can be very kind of sharp or stabbing. So the toothache can be very sharp or stabbing, very sensitive.
Yeah. And it can give you a headache as well, can't it?
It can radiate to other areas as well,
Or
like
temperature.
pain. Yeah, referred pain as well. Sometimes we can experience like a burning type sensation. It can be stabbing or electrical type pain as well. It depends really on the nerve fibers that are affected.
Yeah.
So.
Oh, that's interesting. Right. Okay. Let's have a look. Second question. How do we feel pain? What gives us that inclination that we feel pain? Obviously, we know it comes from the spine, but I'll let you elaborate a little bit.
So pain actually starts when we trigger our nerve endings. So we have some receptors called nociceptors. And each of these nociceptors have a family of proteins. So, for example, TRPV1, transient receptor potential vanilloid family of pain receptors. We also have sodium-gated channels that can relay pain. And P2X3 can relay pain. So we have these specific kind of nociceptors on our nerve endings, and they fire signals along up to the spinal cord and up to the brain, the primary sensory cortex.
Yeah.
Now, once it goes to the brain, we then get like an inhibitory downward type of
response,
a response signal. And normally that can help manage the pain, feeling, the pain sensation.
Yeah.
But if that pain sensation becomes unmanageable and if it goes on for too long, that's when it becomes more chronic.
Yeah, that's right. I know the feeling. Yeah, go carry on.
So we do actually have 3 types of nerve fibers within nerve bundles. And these are like the C fibers, which are like unmyelinated. So they transmit signals slower than other fibers. And this results in like a dull, constant type of pain. And it's also responsive to warmth. So we can sense warmth through these fibers. We also have something called the A delta fibers.
Yeah, that's
these
right.
are slightly thicker.
Yeah.
And they're myelinated, so they transmit signals a lot faster.
Spine. Yeah, they're going to the spine, don't they? Up to the brain.
Yeah. I mean, all these signals do the same.
Yeah.
So, and that results in kind of a sharp electrical type pain. And then we also have the A beta fibers. Now, the A beta fibers are more involved with like mechanosensation, so things like touch.
Yeah.
So these fibers also get activated sometimes when we have a pain trigger.
Yeah.
I actually do have a screenshot of what this kind of looks like.
Okay.
So if I can try and
Go
share my
ahead.
screen.
Share your screen with slides. This will be interesting for our viewers.
Let's see if this works.
This should work.
Okay, so share screen. Okay, so hopefully you can see this.
Yeah, is it coming up?
Can you
I
see?
don't know if I can't see. I don't know if the viewers can see it. I can't actually see it just yet. Maybe the viewers can. I'm not sure.
Let's try.
No, it's not coming.
Okay, let's try again.
Let's have a look. Don't think it's coming up. Oh, here we go.
Has it gone?
There it is. Yeah, there it is.
Okay,
Yeah, it's come up. There it is.
Here we go. We can see like we've got the we've got like 3 fibers here. So you can see like the A delta fibers are like the small thinner fibers, and then we've got the we've got the C fibers, then we've got the A delta, and then we've got the A beta fibers here. So we can see that these fibers are kind of linked in with each other.
That's right. Yeah.
We kind of had this phenomenon where if we sometimes touch the area that's painful, we actually can dumb down the pain.
Okay. Now so touching it can actually relieve some of the pain. Is that right?
Yeah, exactly. Sometimes it can happen.
So pressure, applying pressure.
Yeah, and this is called like the gate control theory. So if we touch sometimes the area, it can help kind of minimize the pain sensation. Okay. I want to now get back to sharing, if that's okay.
That's fine.
Yeah. So in 1965 also Patrick Wall and Ronald Melzack also recognized that cognitive activities can also result in a distraction from pain. So the way we think about pain also can help kind of control the pain sensation. So they acknowledge that psychological processes are an inseparable part of the pain experience. So this is why sometimes CBT is kind of helpful in managing pain patients.
Cognitive behavioural therapy. That's right. Oh, that's quite interesting. Thank you for that. I think somebody called Mekella, she says that she's a sufferer of fibromyalgia, and she's glad that we've got the show on tonight because she's got intolerable pain, and thank you for bringing that to light. So that's really interesting. Thank you for that, Dr. Yilmaz. Right, how do we feel pain? We've done that. Third question, what is the difference between acute versus chronic pain? Now, both of them are painful.
Yeah.
Which one overrules the other?
Well, the acute pain is actually protective. It kind of alerts us that tissue damage has occurred. Kind of helps us also prevent further damage from happening. It's also often short lasting, so it can last from a few days up to, say, less than 3 months. And it's kind of characterized by like an inflammation, soreness and redness, and this is mostly due to an immune response to that tissue damage. So we get a release of kind of inflammatory markers, things like interleukins and other factors get released that result in the pain sensation. And we can actually manage that sometimes quite easily.
Give us an example of an acute pain and a chronic pain, just roughly. Obviously, it depends on individuals, Yeah,
so like an acute pain is, for example, when you fall over and you hit your knee, or if you hit your arm, or if you touch something hot, that kind of pain sensation.
That's an acute pain, yeah?
That's like an acute pain.
Okay.
It kind of gets better with time.
Over time, yeah.
But with chronic pain, this is when the pain becomes more persistent and lasts for longer than 3 months. So if you're in pain for more than, say, 12 weeks, I would suggest that you go and see your GP for medication.
I'll take medication for it to help it, yeah. Because sometimes people may have a pain that they're not actually seeing, they're only feeling, and they're thinking, oh, it will go away. I mean, a migraine or a headache, we know, lasts for a few hours. You rest, you get some sleep, it goes away, or sometimes, or you wake up with a toothache and it's there for days until you go to your dentist to have it removed if there's an abscess or something. So I suppose, again, it depends on the individual of how their intolerances are towards pain. Obviously, some are higher, some are lower. Again,
exactly.
On the individual. That's great too. Okay, so that's the difference between acute and chronic.
So we also have like a neuropathic pain. So the neuropathic pain is actually caused within the somatosensory nervous system, and it's actually neuropathic pain is a major problem actually in Europe. So it affects 1 in 5 people.
And what causes it?
Well, this constant uncontrolled acute pain, so you have a loss of that inhibitory downward processing from the brain, so you have no kind of control over the pain signal, so it keeps firing up to the brain and there's no downward kind of inhibition of that pain signal. And it's also kind of characterized by like a burning, tingling sensation, so you can have that
as a result of nerve damage, do you think, as well?
Yes, you can have that due to nerve damage. You can also get
injury,
allodynia. So pain pain to stimulus that's not normally painful.
Mhm.
So touch, mechanical allodynia, cold allodynia, so allodynia to, say, ice cream,
Mhm.
and also heat allodynia.
Yeah.
You can also get altered sensation, so dysesthesia,
Mhm.
shooting electric shock type pain, and also like enhanced pain
Mhm.
to normally painful stimulus, so like hyperalgesia.
Mhm.
And often people can experience more than one of these symptoms at the same time. So, for example, when I was with the nerve injury patients at King's, we often saw people with a mixture of numbness, pain,
Mhm.
paresthesia.
Yeah.
You know,
So
some
lots
people
of,
also had
yeah.
just numbness and paresthesia. So
Mhm.
these are kind of symptoms that happen with nerve injuries. And
Mhm.
it can also interfere with daily functions.
Mhm.
So, and obviously when daily functions are affected, it will affect your general mood
That's right. Yeah.
and quality of life.
Yeah.
So, yeah.
What would you say is a debilitating sort of pain to live with rather than like a non-debilitating pain, would you say?
So things like migraines,
Migraines,
with me, so
constants. Yeah.
constipatic neuralgia,
Mhm.
diabetic neuropathy as well.
Mhm.
Low back pain can be
Yeah.
debilitating.
Yeah. That's very, yeah, I think.
Pain associated with cancer as well
Mhm.
can be
Or
debilitating.
HIV or something.
Yep,
Yeah.
yeah. So,
Because they lose some of the receptors. Yeah.
yeah. So HIV associated neuropathic pain.
Yeah.
Trigeminal nerve injury. So if you have like a facial nerve injury due to dental procedure, for
Yeah.
example, like wisdom tooth extraction or implant placement as well,
Mhm.
you see sometimes people getting pain.
Mhm.
Sometimes after endodontic treatment. So if
Yeah.
endodontic treatment, they can have overflow of that endodontic filler
Yeah.
into
Yeah.
the nerve, and that can cause pain. Yeah.
Yeah, so that's the
That's it.
pain bit there anyway. Okay, right. Number 4. What are the psychometric effects, and how do we see as a result from the pain?
Well, obviously, pain can cause a lot of anxiety
Yeah.
because
Mhm.
you actually often wonder why I'm getting this pain.
Mhm.
And it can also cause depression because you're not able to do your normal daily
Functions.
activities
Yeah.
because of it. And obviously, that can have emotional effects,
Mhm.
and you're not able to maybe cope with the pain. You might catastrophize about the pain as well
Mhm.
because you don't know the cause. And all of this can actually lead to increased pain sensations as well.
Mm.
So it can actually make the pain worse.
Yeah.
So you've got to try and stop that kind of vicious cycle
Yeah.
of
Absolutely.
the pain sensation.
Yeah. Yeah. Absolutely. Yeah. Okay. What else we're going to ask here? Right.
We
Yeah.
do
Go
actually have quite a lot of pain questionnaires as well, and
ahead. Mhm.
psychometric questionnaires that we can
Mhm.
use. So,
Mhm.
for example, we can use the chronic pain acceptance questionnaire, which
Mhm.
assesses whether the person has accepted that the pain is present.
Mhm.
And we also have the pain catastrophizing scale,
Mhm.
so whether they're actually catastrophizing about their pain. We have the OHIP 14, which measures the health impact,
Mhm.
and also UOQOL, so quality of life
Mhm.
assessments. We
Mhm.
have the pain self-efficacy questionnaire, so the ability to cope with the pain
Mhm.
and perform specific tasks despite the pain.
Mhm.
We also have something called the pain detect questionnaire, but
Mhm.
that's mostly adapted to low back pain.
Uh-huh. Yeah.
So we can also kind of manage the psychometric effects with CBT,
Yeah.
like I said before,
Yeah.
behavioral interventions,
Mhm.
mindfulness-based stress reduction.
Mhm.
Tai Chi is known to be very good.
Yeah.
Yoga
Yeah.
and kind of frequent exercise is very good,
Mhm.
and dance. So
Yeah. They're all good exercise. Yeah,
these
exercise is
are
good
all the
fun. Yeah.
things that help to boost your mood and morale.
Yeah. What do you say about diet when it comes to pain? Do you think diet plays a key role? And I know some people say if I'm in pain, I'll take a glass of wine or a spirit or something. What's your views on that, would you say?
Yeah, some patients have actually said that they do drink the alcohol,
To help
but
with the pain?
obviously to help with the
Hopefully not with the
pain.
medication at the same
No,
time.
exactly. But
Yeah.
unfortunately, that can lead to a spiraling. It
Yeah.
can lead to bad things as well, because we have seen alcoholics come to clinic
Yeah.
too,
Yeah.
unfortunately. So yeah, to a certain degree, it's okay,
Yeah.
provided that you can control it. But if it spirals out of control, then that's when it becomes dangerous. Because I remember a patient very vividly on clinic. He came in very suicidal.
Oh wow!
About
Oh my
pain.
gosh.
Yeah, we see a lot of suicidal patients actually due to pain, and yeah, we had to basically try and calm him down a lot, refer him to the emergency kind of psychiatric help.
So as a result of pain, like back pain.
Yeah, it wasn't back pain; it was facial pain. So,
okay.
And you've got to remember that facial pain is actually can be worse than any other type of pain because
there's tissue around the face or.
And we've got higher representation in the brain, so 40% of the cortex is represented to the face. So we actually feel pain a lot more when
in
it's
the face
because it's more emphasized. Yeah.
Okay, that's interesting. Some nice comments coming up. A lady called Bernadette Woodland, she's put here, your programs are very informative and they deserve to be on national TV. Good luck for the future. This is really interesting. Somebody called Nashida Jamal, we are very proud of you, Dr. Zehra Yilmaz. So there you go. And again, Bernadette Woodland, what are your thoughts on acupuncture, Dr. Yilmaz? What's your thoughts?
So acupuncture has been actually shown to be useful as well. So like an alternative method, especially for back pain. So yeah, I would recommend acupuncture as well.
Okay, well there you have it, Bernadette Woodland. So
moderate
exercise, right? I think this lady I've known her quite well actually. She suffered a stroke many years ago, and also other issues as well. And she went to she had Pilates. She does Pilates as a routine to sort of get some of the cognitive and physical functions back. So Pilates, is it something that you would recommend to people as well to help with pain?
Any kind of exercise really can be beneficial for patients, for people. So actually staying still, like sleeping too much, like lying down too much, can actually make painful. Worse. It can make it worse. It can make your muscles seize up.
That's right. Yeah.
Worse.
Along with bed sores as well.
Yeah, exactly. So try to move as much as possible.
So the message is keep active, definitely.
Yeah, keep active. Don't sit down too much, otherwise your muscles seize up.
Yeah, to seize up.
What you don't use, you lose. So
that's exactly it. Don't lose it, you lose it. Absolutely, Dr. Yilmaz. Brilliant. Thank you for that one. And we've got here number 5. What medications can we use to treat acute and chronic pain? So if we start with acute pain first, what sort of medications can we use?
So we have the standard kind of aspirin, also paracetamol. Obviously, we've got to be careful with like the
gastrointestinal tract,
exactly. Neurovascular and the cardiovascular implications too. So only take painkillers that you're allowed to take. So things like ibuprofen, naproxen, diclofenac, celecoxib, mefenamic acid is also kind of good for kind of acute pain. Second line, the therapies can also include tramadol, duloxetine.
Things like amitriptyline and gabapentin for nerve pain, can't they?
Yeah, that's more for kind of chronic pain.
The long-term pain.
Yeah, the longer-term pain, we use the low-dose tricyclic antidepressants like amitriptyline, doxepin, imipramine.
Yeah.
And because these kind of help to inhibit the reuptake of the feel-good chemical serotonin.
Yeah, that's right.
Once we have more serotonin in the system, then obviously we'll feel better, and the pain minimizes as well.
Yeah, that's right. It decreases. That's right.
Yeah, and we can increase our mood improves as well.
That's right. And obviously vitamin D is another good one as well, because I know especially with lockdown, a lot of people sort of suffering with like chronic pain that they've got because they're not moving around. Vitamin D is absolutely crucial. What do you say with chronic pain?
Well, like I just said, so like the antidepressants, duloxetine, anticonvulsants like gabapentin can be used, morphine in the extreme case.
And what about for migraines? What would you say for migraines? People who suffer repeatedly with migraines every month, what would you recommend?
Well, over-the-counter painkillers are quite useful, actually. They're quite useful.
Yeah.
Things like the NSAIDs are quite useful for that.
The non-steroid ones.
Botox has been shown to actually help as well with pain, but that's kind of like a quite
last resort.
I wouldn't suggest that everybody goes straight to their Botox.
I don't think they would do it straight away, but that's fine. Okay, brilliant.
Things like surgery is also helpful. So
For migraines?
No, not for migraine.
I was
For
going to
like
say.
for chronic pain.
Yeah, for chronic pain.
Going
Yeah.
back to chronic pain. Some kind of alternative therapies as well, because sometimes these anti-inflammatories, no, the antidepressants can be, they have a lot of side effects.
Side effects, that's right, yeah.
So we need some kind of topical therapies as well. Things like topical gels, sprays, creams that contain painkillers like paracetamol, ibuprofen.
Yeah.
Capsaicin is also a very good painkiller.
Yeah, that's right. I've heard of that. Yeah, things like that.
Because that actually activates the TRPV1 channel, which is known in pain signaling. So once you have a certain threshold of capsaicin, it actually has a numbing effect. So you feel the pain at first, but then it becomes like a numbed sensation.
Yeah.
Versatis patches also is very good. So things like, because that contains 5% lidocaine, and patients can wear that over the painful area. We've seen that a lot in our facial pain patients. So they wear it sometimes like over the jaw.
Okay.
And
is that a temporary measure or is it permanent? Will it be permanent?
Well, they wear it for like 12 hours a day.
At a time.
At a time, and it can be for say 6 months at a time, and we see how they progress with the pain. It kind of works because the patches contain the lidocaine, which kind of gradually seeps into the skin, so it kind of provides a gradual pain relief over time.
That's right. Yeah.
It's also been useful in postherpetic neuralgia and diabetic neuropathy and low back pain. So we have seen different size patches can be used. So obviously you can cut the patches depending on the size of the area. I do actually have another picture of somebody wearing the patch. I don't know if
that'd be great if you could get it up. Yeah, that's fine. Somebody called Mehmet Yilmaz has said he's very proud of you too, and can you discuss pain related to teeth implants? So obviously someone who's had teeth implants, pain related to that. Somebody would like.
Sure. So with tooth implants, sometimes the implant can cross the nerve when they actually place the implant as well. So we've got to be very careful with the length of the implant that's placed. So very, very careful planning needs to be done. We need to have scans. So Combing CT is very good at planning implant placement because it allows you to see like a proper 3D kind of image of the nerves, of the inferior alveolar nerve, which travels along the mandible.
Mandible, yeah.
So, and also the maxillary branch of the nerve, which is the upper jaw as well. I can just show you the picture as well.
Sure.
That'd be good. Let's try again.
We've still got about 5 or 6 minutes, so go ahead.
Okay, sure. Okay, so I just thought this would be quite useful because
go for it.
Because some patients actually wear it during the day because it kind of helps protect against pain.
Skin color as well, so it doesn't.
So some people actually wear it with makeup. Some people actually wear it with makeup. They cover it with foundation.
Yeah,
okay. It kind of protects with the cold allodynia. So if there's any kind of wind, for example, it can help minimize the pain.
Yeah.
So that's why some patients actually prefer it during the day rather than nighttime. And like I said, it can be worn in different areas of the face as well. Okay, that's not kind of working at the moment. Let's try again.
It's okay. We're not stuck for time, so don't worry. Oh dear. Somebody just said something here. Would Dr. Zehra recommend alcohol as a pain suppressant?
As a what, sorry?
A pain suppressant. Right, okay. Let's
is that working? Yeah.
Oh yeah, that's fine. Yeah, that's brilliant.
So
we can see the patch there. This is what Dr. Zehra's put up on the screen, people. So there you have it. That's a pain patch.
So this is how some patients actually wear the pain Versatis patch. And this contains a lidocaine, which is the anesthetic, and it acts on the sodium channels on the nerve endings. So this is how pain is actually minimized. I like to say that Botox can also minimize pain, and we showed that actually in migraine patients. So we can see that actually before pain,
so halves, almost half.
So we actually see significant kind of decreases in pain thresholds.
And that's with just normal migraine.
Yeah, and other kind of cluster headaches as well can help with.
Brilliant.
So yeah, let's get back to that.
Right.
Okay.
So I think that would be no. So alcohol isn't a pain suppressant. So someone was asking.
No,
Okay.
no.
Some of our viewers. Okay.
I
Let's
wouldn't
have
recommend it. No.
What alternative methods can we use to manage chronic pain? I think that's our sixth question for the evening.
So like I said, so the topical approaches, we have the CBT, reassurance and counselling can help, yoga, Tai Chi, certain lifestyle changes as well, things like starting hobbies that you might enjoy, because doing something that you enjoy can actually help you feel better, can help you minimize the pain sensations as well, and it actually increases your serotonin levels, so that's beneficial. Happy chemicals. And physical therapy as well can help in certain conditions, so things like back pain, leg pain.
So stretches and stuff
can help.
Like that.
Stretches can help.
Okay. And obviously, like you said about lifestyle changes, I know with some chronic pain where people are severely overweight and they have like joint pain on their knees, the amount of patients I've seen that have gone into hospital to have like knee surgery because they're so overweight, and like sometimes the consultants will not operate until they've lost like at least half their body weight. So that in itself is a strain, obviously not on the NHS, but obviously on the patient and the doctor sort of like seeing the patient. So again, lifestyle changes will obviously
things like diet. So making sure you eat well as well, so that that will help you lose the weight. Sometimes when you're overweight, you can't move sometimes.
That's one of
because
the
you're
problems.
in pain as well. So it's like a vicious cycle.
So
kind of start off with the improved diet, try and reduce the weight that way, and then you can hopefully exercise better, gradually increase the exercise over time.
That's right.
Because you can hopefully get better with time as well. So things like an exercise bike. Dancing is very good as well if you want to at home, especially in these lockdown conditions.
Exactly. It's true. Or just dance to the TV, or put some YouTube on and just dance.
Exactly.
Just make sure you've got enough space to do it before, so don't give yourself an injury. We don't want that. Okay, what else was I going to say? Now we've talked about pain and chronic pain and acute pain. What other types of pain are there that are not physical, would you say?
Well, we have the emotional side of it, cognitive side of it. So we have to try and deal with those sides as well. It's very important.
Cure for that.
Yeah, exactly. Well, when I was at King's, we actually worked with a multidisciplinary team. So it actually involves psychiatrists and psychologists as well. So if we weren't able to manage the patients with a lot of medication, we would actually also refer them for CBT for the actual psychological help as well. And that did help these patients out. So those patients that are overly anxious or depressed, I would actually recommend them being referred to psychiatrists as well and psychologists to kind of help the emotional side of pain.
Because obviously pain is different to everybody, not just the physical pain, emotional pain. Obviously, we've been in lockdown for like 12 weeks, so people are feeling different types of pain, not only because they're not exercising or because they're not seeing their loved ones or whatever, because they've experienced trauma from an abusive partner or something. Or
trauma can be a very lasting effect on anybody.
Exactly.
Any kind of grievance as well can be.
Grievance is the worst one.
So if you've lost somebody as well, especially during this time, that can also have a very bad effect on you and affect your pain levels. So
before we finish off, Dr. Zehra Yilmaz, what I was going to ask you is inflammation, because obviously someone was asking about inflammation. What sort of things can help reduce inflammation?
Depending on where it is.
Okay,
So it depends on where it is. If it's a topical kind of pain, I would recommend the gels and sprays. That
just gels and sprays,
or paracetamol.
Like paracetamols and stuff. Obviously, to check with their doctors to make sure they can take it. Sometimes, if they're already taking medication, it can contra what they're taking. So we don't want to sort of give bad advice or anything. But always check that what you're taking is adequate. Okay. Is there anything you'd like to finish off with, Dr. Yilmaz?
I'd like to say that we also have 2 websites that I've very proudly kind of developed with my colleagues while I was at King's. These websites are on trigeminal nerve injuries and also oral facial pain. So I would recommend anybody with like migraines, headaches, any kind of facial pain to kind of go to these websites. The first one is on trigeminal nerve injuries. Now, trigeminal nerve injuries can happen due to kind of wisdom teeth extractions or any other kind of dental procedure. It can also occur due to infections or abscesses. So if anybody has that kind of injury, they think they have that kind of injury, I would recommend the trigeminal nerve injury website.
Maybe you can put the link at the bottom of our post this evening, or just put paste it or something.
I'll do that later. And also the oral facial pain website, which is more for the general kind of tension headaches, head migraines, those kind of facial pain conditions. So I would recommend them to go to these kind of websites for kind of more information about the conditions.
Okay, that's brilliant.
Yeah.
Thank you so much for coming on the programme this evening, Dr. Zehra Yilmaz. You've been an inspiration, you really have, and you've had quite a few followers I can see from here and all the comments and everything. So thank you so much for that.
Thank you for the invite again. And
yes, thank you so much. Hopefully we can have you back on the show if we decide to film again in the future. You've been really, really great, and you've had some really positive comments there, Dr. Yilmaz. Thank you so much. Thank you. I'd like to thank all the viewers who've been watching as well, who've been watching the programme this evening, and to all the lovely comments, really positive. Thank you so much for that, people. And we look forward to seeing you again soon next week. Tuesday will be our last show. See you soon. Good night.
Bellona'dan büyük indirim. Şık tasarımlarıyla ev hanımlarımızın hayalini süsleyen Venti yatak odası takımı Bellona şubelerinde sizleri bekliyor. Bronz aynası, dairesel kulp tasarımı, yerden yüksek yapısıyla temizliği kolay, storage alanıyla fazlalıklarınızı saklayabileceğiniz Venti yatak odası takımı yalnızca 2395 pound. Evet, yanlış duymadınız. 5 kapılı Venti yatak odası takımı 3700 pound yerine şimdi yalnızca 2395 pound'a sizleri bekliyor. Hadi hemen 266-270 Enfield High Street ve 219-221 Lewisham High Street'te bulunan Bellona şubelerimize gelin, yatak odası takımını alın gidin. Haydi bu fırsatı kaçırmayın. Yine sizin için, yine Bellona.